All right, welcome everyone. Um, Today's webinar is Grief Through Different Lenses, Survivors and Communities. This webinar is being hosted by Great Lakes ROTA-RC's regional partner, Ohio State University Extension, and Ohio Youth Resilience Collaborative based at Ohio State. I'm your host, Kelly Cabral. I'm a project director with the Ohio Youth Resilience Collaborative. Before we get into our presentation, we have a few quick housekeeping items to address. First, let us take a moment to acknowledge our funder and funding activity. The Great Lakes ROTA-RC is funded by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, to provide training and technical assistance to the rural communities within the Great Lakes. Collaboratively, we develop and strengthen community capacity to prevent, treat, and support recovery for opioid use disorder and other mental health conditions and substance use disorders. Through cooperative extension state programs, we employ evidence-based emerging practices and provide virtual and on-demand education for rural community members regarding substance use education and other relevant topics in mental health and substance use disorders. In communities with Indigenous populations, the project co-creates culturally responsive, holistic health education and resources. We also provide evidence-based resources and research, as well as technical outreach to professionals working in and with rural communities. We invite you to learn more about the Great Lakes Rural Opioid Technical Assistance Regional Center, its resources and partners by participating in our grant products. You can see here, and we'll make sure you get a link to this page after the follow-up email from today's session. But we have a variety of virtual education, newsletter articles, news and updates, and we'll have toolkits as well, which will be developed after today's presentation regarding grief. Some additional items here, you can see we have our Great Lakes ROTA-RC newsletter. That does provide regional highlights that includes projects that are ongoing throughout SAMHSA's Region 5, as well as events like today's that you can participate in across the region. As we prepare to listen and engage in the session content, let us take a moment to promote the use of affirming person-first language when discussing behavioral health disorders. As we create an environment of learning together, let us create a learning space that is welcoming and safe for everyone. As a virtual learning community, we ask that all participants support non-stigmatizing, recovery-oriented language that can help reduce negative bias and promote engagement. We invite your active participation from whatever space you are joining us today, and we welcome you formally into the Great Lakes ROTA-RC virtual learning community. For today's session, we are lucky to have two presenters speaking to us about grief. So I'm pleased to introduce our first speaker, Allison Schlosser. Dr. Schlosser is a medical anthropologist with a background in social work and public health research. She's an assistant professor of anthropology at the University of Nebraska, Omaha. Allison specializes in the intersections of culture and substance use and societal responses to drug problems in the United States. Her research draws on in-depth ethnographic and other qualitative research methods to examine lived experiences of residential treatment, medication treatment for opioid use disorder, risk reduction services, drug overdose survival, and drug overdose death bereavement. Thank you so much for joining us, Dr. Schlosser.
Thank you, Kelly. I'm going to go ahead and share my slides. Can you all see and hear me okay? Great. Well, thank you, Kelly, for that wonderful introduction. And thank you to Kelly, Pam, and the other organizers of this event. Today, I'm going to be talking about lived experiences of loss in the U.S. drug overdose crisis. And I want to start with a note, just recognizing the importance of this conversation that we're having today. As many of you are familiar with, there is profound stigma related to drug use and overdose death. And breaking the silence and really having conversations such as these is a really important step in ameliorating the suffering that goes on when people are grieving drug overdose death. So in today's talk, I want to start off with a little background on the scale of the loss in the United States. And then I'll talk about the idea of special grief, the particular situations and experiences that emerge in the context of drug overdose death. Then I'll spend some time talking about research on lived experiences of grief among different groups of people, including family members, people who use drugs, and services providers. And then I'll close with implications for future interventions that might help to ease the suffering related to drug overdose death bereavement. And in terms of the objectives for the session today, I hope that after participating in this session, you're able to identify the main social and structural contexts that shape drug overdose death bereavement, that you will have an idea of the research on complex grief in response to drug overdose death bereavement, and we'll be able to apply knowledge from research on drug overdose death bereavement to explore interventions to better support individuals, families, and communities experiencing drug overdose death bereavement. So just a little additional background about me. I am an assistant professor of medical anthropology at the University of Nebraska, Omaha, and I had previously been doing research in Northeast Ohio for about 10 years. I'm a medical anthropologist, and what that means is that I'm interested in the intersection of culture and health. And from the start of my career, initially as a social worker, I've been interested in how people experience drug use, substance use disorder, and related interventions, drawing on qualitative research methods that really get at people's lived experiences of these interventions and experiences. And I do what's called ethnographic research, which really focuses on using in-depth interviews with people and observing what's going on in their lives in their everyday context of life and also in the context of interventions to ultimately develop better interventions that meet their needs and preferences. I've done research in drug courts, community-based prevention programs focused on overdose, particularly naloxone distribution, residential drug treatment, and also medications for opioid use disorder treatment. And again, my focus across all of these contexts is understanding lived experience. So I'm sure, again, we are all aware of the profound loss that has happened in the United States and some other places in relation to the opioid-related overdose crisis. Since 1999, in the United States, over 1 million people have died of a drug overdose death. And you could see on the figure here the sharp rise in drug overdose deaths from 1999 to 2022. And as of spring of 2023, 32% of the US adult population, which is just under 83 million individuals, have lost someone that they know to a fatal drug overdose death. So the scale of the loss is profound here. What research tells us from drug overdose death bereavement in other places in the world, including Scandinavia, the UK, and Canada, as well as some research in the United States, although there's a need for much more, is that we see particular processes of grief in response to these drug overdose deaths that are sometimes called special grief. These deaths are sometimes called special deaths, similar to deaths by suicide and accidents and murder. And there are three features of these types of deaths that particularly shape the grieving process. And this is taken from some research that you'll see cited at the bottom of the slide, particularly research by Templeton and colleagues out of Norway. The first prominent feature of these deaths is stigma, and this includes multiple levels of stigma in the experience of drug overdose death bereavement, including self-stigma. So we could think about the stigma that parents might experience in terms of their feelings of shame and guilt of not being able to help their loved one survive. We could think about the broader scale social stigma, so messages around the values of these lives and how we should respond to their deaths. And also structural stigma, so the ways in which social structures, including health and social services systems and the criminal legal system, shape people's ability to recognize and grieve these losses and consider them as valid lives and losses. Second, we see often traumatic circumstances of the deaths, including dying alone, dying in one's home, and having one's loved one die when you are present, witnessing the death. Connected to both of these first two features is what's called disenfranchised grief. And this is a dynamic around the belief that these deaths are not valid deaths to grieve, the idea that they are ungrievable deaths, undeserving of grief and memorialization. And this is connected to broader dynamics around societal and structural stigma related to drug use and drug-related overdose deaths. So this really profoundly shapes the grieving process. A couple of important additional considerations are anticipatory grief. So one participant in an interview study on these special deaths called this living bereavement. And this is the experience of loved ones being aware of the drug use of their family member, friend, or peer, anticipating that one day they might die a drug-related death, and really having that anticipation shaping their emotions and everyday practices around grieving even prior to the death. And I'll talk more about this through some examples from the research in a few moments. It's also important to recognize dynamics around interrupted mourning that may take place in the context of these deaths. This occurs when these really important mourning practices and rituals like funerals, memorializations, public processes of mourning are obstructed or otherwise interrupted because of the stigma related to these deaths. So going back to this idea that these are ungrievable deaths, unworthy of public memorialization, but also sometimes contexts of institutional involvement. So things like police investigations that might prevent a funeral from going forward for some time, or even the experience of people who are grieving drug-related deaths being in institutional contexts that prevent them from attending funerals or otherwise mourning, for example, being in treatment or being incarcerated themselves. And again, I'll talk about a few examples of that going forward. So these contexts of special deaths and special grief can lead to what's called complex grief. And complex grief is marked by persistent feelings of debilitating loss, resulting in an ongoing heightened state of grief that may hinder one's ability to feel the pain of the loss, to adjust to life without the deceased, and to foster new relationships. So really hindering that ability to really confront and process the loss and really build a life moving forward. So you can imagine complex grief is very painful, and it plays out sometimes in slightly different ways, depending on one's relationship to the deceased. I'm going to go through some research that draws mainly on in-depth interviews with people who are experiencing drug-related bereavement from different perspectives. And I'll start with what is the most common research in this area, which is on experiences of drug-related death bereavement among parents. Teitelstedt and colleagues and other researchers in Norway have done a lot of research on these experiences, but there's also some in Canada, the United States, and the UK. But I'll focus on one study out of Norway looking at these dynamics. And they have published on this and put forward a really kind of helpful model to understand the complexities of this sort of complex grief that occurs among parents. We can see here on the image the anticipatory grief that I talked about that shapes an experience of having an overload of complex emotions. Sometimes the experience of extended parenthood, so feeling really responsible and having a lot of caring responsibilities for one's loved one into their adulthood as they experience problematic drug use, and managing societal stigma even prior to the death, really causing a lot of complex difficulties for them emotionally and socially prior to the death. Regardless of the anticipation of the death, parents in this and other studies often still experience that death as a shock, which then led to further emotional overload and complex reactions to the loss, which was made even more difficult from dynamics of disenfranchised grief, a lack of consistent help from health and social services agencies, and often an experience of self-stigma. So those dynamics around self-blame and guilt for not being able to help their loved ones survive. Participants in this and other studies also experienced many challenges in basic communication around the loss to both services providers, but also friends and family. And all of this often leads to highly intense grief reactions, and again, those complex grief reactions. So I want to share with you some direct quotes from parents who participated in these studies. So grieving parents, again, often experience these complex emotions, and anger is often a central part of these emotions. And we see this in other grieving processes, but we can think about the ways in which this anger might be intensified in the context of drug-related death bereavement. So one parent said, "I'm angry at her," referring to the deceased. "I'm angry at the healthcare services. I'm looking for someone to blame. So if I can't blame myself, then I must be able to blame someone else. And then it must have been someone else's fault, probably the healthcare services or child welfare or the police." Parents also, in addition to this intense anger and kind of seeking someone or some entity to blame, experience very difficult communication. And again, this is with a variety of different others in their lives, including family and services providers. So one parent stated, "I think others do not know what to say and how I will react. Some people find it very difficult if others get very emotional, starts crying, for example. Others find it very difficult to handle that. I have siblings who are health professionals. I thought that maybe they would try, but it seems difficult even for them. There's no unwillingness, they just don't know how to react." And we see in this research and these experiences a pretty intense social isolation that could emerge from these complex emotions and difficult communication. And this is sometimes exacerbated by a lack of help from services. And so a couple of quotes here really reflect the challenges of accessing and engaging with needed services in the grieving process. One parent from the Titlestead study said that the first to arrive at the scene of the death were the doctors and the ambulance staff, and then came the police and morticians. And somebody told me that if I needed to talk to someone, I could call someone. She then laughs. "I received a number for a crisis relief team. I tried to call once around Christmas, but they closed at 8 p.m., so there wasn't much help in that." So being offered some service, but really not being able to take advantage of that in this context. In a related study by Templeton and colleagues, which took place in the UK, reveals a dynamic that is also echoed in my own research on this in Northeast Ohio, which is around experiences of having involvement with the police and potential investigations and prosecutions following the death, really shaping one's experience in a way that sidelines the grieving process of loved ones and makes this criminal legal intervention primary, which was troublesome to some people involved in this research. So one parent said, "I thought there was no emotion or anything with the prosecutor involved. It was just a job. I felt her mannerism wasn't somebody with compassion and empathy. The police were more interested in getting the drug dealer and the names of who their son had been with. He was just another drug death." So in this research, there is a mixed bag in terms of the responses of people involved in institutions, including the criminal legal system and health and social services, but more parents in particular recounted some discomfort and negative experiences with these institutions in the wake of drug overdose deaths. I also want to talk about research on grieving among people who use drugs themselves, who may be in and out of problematic drug use. And this is from research that I conducted in Northeast Ohio with my collaborator, Lee Hoffer. We interviewed people who were engaged in overdose prevention. So they were seeking naloxone and participating in naloxone training. And what we found when we asked these individuals about their experiences of witnessing, responding to, and losing people in their social networks to drug overdose deaths is that people often were very eager to talk about these experiences. They didn't feel like they had a lot of opportunity to share them and work through them. And these experiences were marked by several themes, including conflicted social relations with the person who died of drug overdose death and their family, and also experiences of survivor's guilt. So I'll share Armando's experience from one study on this topic. He said that my one friend I grew up with, Chad, he overdosed and died. It made me feel guilty because I'm not going to say I didn't start it. He obviously did shit on his own, but he was my friend and we got high together. We went to the same place together. We split off, stopped. He started doing his own thing, hanging out with different people, getting high. And I don't know, his whole family, they thought I was responsible for it. I sold him the dope or this or that. And I went to the funeral and it was an effed up situation. I asked, did it influence your drug use at all? And he responded that initially it made me get high more for real. It kind of put me in a depression. I just kept getting high. And this response was typical in this study of people who lost someone to a drug overdose death who was a close friend. They often experience this dynamic of responding to the loss by sometimes self-medicating that pain by increased drug use, and then toggling between that and reducing or eliminating their drug use in order to prevent themselves from dying like their friend or other loved one had. We also found in this study experiences of interrupted mourning and limited grief support. So I want to share, to reflect these dynamics, the experience of Amanda. She lost her brother to a drug overdose death while she was incarcerated. Once she was released from prison, she was living at a transitional housing facility. And she, unlike others who participated in this study, received grief counseling while she was in the transitional housing facility. But she was eventually discharged from the program because of a rule violation that didn't have to do with a return to drug use. And so she describes this here. I asked her, you talked about your brother passing away. How has that affected you? And Amanda explained that, I guess because I never got to say bye to him while she was incarcerated and he died. It's really affected me, but I think it's put a whole new perspective on why I do it. Now, not that it's right, but I don't ever want to make my mom feel that. I talk to him, her brother, though. He watches over me. And she explained that she remained connected to him. She said, I was in grief and loss counseling in this sober living, so everything's kind of dropped off now. So she really appreciated this grief and loss counseling. And she was, in fact, the only participant in this study that received specific grief and loss counseling. But unfortunately, this was not consistently available to her because of her housing situation. I also want to talk about a couple of experiences that reflect themes from my research on people's experiences of grieving in the context of their own residential treatment. These experiences really highlight the need for specific grief and loss counseling for people who are going through residential substance use disorder treatment. So Dave is someone who I interviewed over a year while he was initially in a residential treatment program, and then in transitional housing after. And he had lost his mother of a drug overdose death prior to entering the treatment center. He was really challenged the entire time while he was in treatment in processing this loss. And while the program delivered some one-on-one therapy and 12-step groups, it really wasn't equipped at this time to provide specific grief and loss counseling. And this research occurred between 2014 and 2016, a time of rapid rise in drug overdose death in the region where this research took place. So providers really felt pretty ill-equipped to respond to the needs of grieving residents. So Dave explained, I always see my mom in my dreams, but I can't get a clear visual. You know what I mean? Like her face. I know she's my mom and I call her mom, the sight of her, because I'm slowly forgetting what she looked like, but I got pictures of her. It's weird. And we're always using or fishing. My mom used to fish with me a lot. Yeah, she was cool like that. So he was really experiencing his great grief, even in his dreams, and really struggling throughout treatment to process this loss. Another example from a resident in the treatment center where I did research that also really reflects the need for grief and loss counseling is the experience of Drew. So Drew had a roommate in treatment named Jackson, and all the names that I use in this presentation are pseudonyms to protect participant confidentiality. But Jackson had been discharged from treatment, and Drew was very concerned that Jackson would die of a drug overdose death after being released. And this is something that he sort of thought through and struggled with after Jackson was released. And this kind of connected with his experiences of the drug overdose deaths of many friends and family members over the course of his life. Jackson experienced what he felt was a real lack of understanding and support from some of the staff at the treatment program. So Jackson explained that Drew explained that the day after Jackson left, I had fallen asleep kind of early just to take a little nap, and I had a terrible drug using dream with him in it. My roommate woke me up and we had to go to a meeting. I was 5 minutes late and I went downstairs to sign in. I had been crying the whole time I was getting ready, and I was trying to get my composure back so I didn't have to go crying in front of everybody. Because I was the last person, Joan, a resident assistant at the program, didn't let me sign in. I just left. I sat down for a little bit, waited for Joan to leave, and I went back to my room and cried. The staff, don't pay attention to stuff like that. So after this experience, Drew explained that he felt that staff in the program, especially resident assistants who have the most contact with people in treatment, weren't really prepared and didn't know how to respond to the experiences of loss like Drew's. And this leads to the very limited but very important research on grieving among services providers. So Drew's experience, I think, reflects a broader dynamic that I and others have observed in doing this research, which is the emotional toll that experiencing clients for service providers who have died of drug overdose death takes on them. Now, there's not much research in this area and much more is needed, but there's an important recently published study by Kala and colleagues, which took place in Toronto. And they interviewed overdose prevention services providers in the Toronto metro area. And they really identify how the scale of the overdose crisis leads to an experience of emotional overwhelm among these providers. So one service provider explained, I think before, when there was time between, I would have time to process and think about it. But it just starts to compound. It does bring up a lot of other losses. And then you're like suddenly triggered to deal with it in a particular way, or you're thinking about it in a particular way. So really identifying that the experience of death after death after death really provides very little time to process these losses. This combined in this context with a lack of workplace support and a sense that there is not the political response to the overdose crisis that's warranted given the scale of the loss. And the lack of workplace support here is often connected to these service providers' experiences of being at a fairly a direct service provider role where they might have a lot of contact with people who are going through overdose prevention or treatment services, but not necessarily being full-time employees who receive a variety of different benefits, including benefits of health insurance and opportunities to get supported grief counseling. And also these individuals may be volunteers, really lacking support in the workplace. So one service provider explained their experience of this. They said, I spend my weekend in the thick of the grief with no work support and with a family that's saying, well, it's just your client. So really feeling left alone in their experience of grieving here. So I want to talk about a few current supports that have really been highlighted in my work in Northeast Ohio and in other research on lived experiences of grief. And the first is a family advocacy group that some of you may be familiar with called Broken No More. So these are family members who are responding to the loss of a loved one to a drug overdose death by doing advocacy for meeting the needs of family members for grief and loss support, and also advocating for the needs of family members in the context of responding to the punitive sort of responses to drug overdose death, things like efforts to prosecute people who may have used drugs or exchanged drugs with their loved one as a drug-induced homicide, and family members really advocating often against those approaches, identifying them as potentially compounding the harm and suffering related to drug overdose death, and really advocating for more caring and supportive and approaches to reducing the risk of drug overdose death so that other families don't have to experience these losses. So Broken No More does a lot of good policy advocacy and supportive events for family members dealing with grief and loss due to drug overdose death. A related group that focuses on support groups and has local chapters across the United States is called Grief Recovery After a Substance Passing, GRASP. And you could look up in the resources that are shared after this presentation on the link, the local chapters that are available to participate in grief support groups for people who have lost someone to a drug overdose death. And finally, I've seen a lot of promise in arts-based projects that help to work against this disenfranchised grief that we see related to the stigma of these losses. So just one arts-based project that really focuses on helping family members and other loved ones memorialize their family member who died of a drug overdose death and make these losses important and public is called the Health Story Collaborative. This is a project that looks at health, healing, and loss experiences over the course of a variety of different health areas, but has a particular opioid project. It's led by Annie Brewster at Harvard University, and it's a project in which people who have experienced difficult health challenges, including drug overdose death, have the chance to create art to memorialize their loved one and to tell their story about their experience of their loved one and their experience of the loss, really memorializing that individual. And if you go to the link for this project, you can see the art that's been created by loved ones and also listen to short 2 to 4 minute audio narratives of their experience of their loved one and the loss. And finally, I want to close with some implications of the research on lived experiences of drug-related bereavement that we could think through as we move forward to create better interventions and more supports for all involved, including family members, peers, and services providers. So clearly there's a need of grief and loss support for family, friends, and peers that is primary in their experiences and not subordinated to other goals. And so that experience of having one's grief being subordinated, for example, to police investigation or other aims, what sometimes is called grief subordinated to justice, was important in the research, particularly with parents who have experienced these losses. There's also a need of grief and loss support that's specifically informed by the experiences of people who may be ongoing in their drug use, and also for services providers. And these are two groups that we have relatively little research on their lived experiences. So really understanding better their unique positions and experiences of grieving is important. For services providers, there's some helpful research on the experiences of service providers after the loss of a client or a patient to suicide that can be helpful here. And there's a paper by Yule and Levin that talks about how we could draw lessons from those experiences to apply to drug overdose death. And they highlight the need for service provider supervision immediately post-drug-related death, and particularly training for services providers on these really challenging interactions with family members who are experiencing their own grieving that may include really intense anger that we saw through some of the previous research. And also really highlighting the value and importance of peer support among services providers who may feel like they have not been given a lot of training and supports on dealing with these difficult situations. There's also a need to really make central grief and loss support in substance use disorder treatment. Really understanding that people's experiences of loss that they bring with them into treatment and also may experience in the course of their residence in a treatment center are really primary in their minds and experiences of recovery, really enfolding into their experiences of recovery and not separate from or secondary to those experiences. And then finally, thinking about the ways that we could support more collective grief and memorialization for affected communities, and understanding that these communities are often affected in their lives in multiple ways. So understanding that services providers may have their own experiences of losing loved ones to drug overdose death and may have their own experiences of surviving a drug overdose in the past. And these are very difficult experiences to have, but we know that people are not alone in these experiences. So understanding that these communities exist and that there's a need for collective grief support. And again, going back to the promise of approaches like art-based projects that really publicly memorialize and make valid these losses and the grieving that goes on in response to them. So with that, I'll close by acknowledging the funders of the research that I talked about today and all of the participants that made this research possible. And by inviting you to please contact me at this email address if you have any questions or want to discuss this topic further. So thank you all for being here.
Thank you so much, Allison. And I really appreciate you sharing some of those resources. We'll make sure when we develop our toolkit to send out to everyone that we include some of those so that you have the links to those. And there will also be a recording, and the slide decks will be up on the website that you'll all receive as well. I want to now move on to our next speaker. We will have time for questions after both speakers are finished. So I'd like Nicole to go ahead and get herself set up, and I'll do a quick introduction for her. So our second speaker today is Nicole Barnes. Nicole is an 18-year employee of Park Nicollet Healthcare Services and joined the Park Nicollet Growing Through Grief program in the summer of 2017 as a program manager. She has many years of experience in social work and healthcare leadership. Her current role includes partnering with 9 Growing Through Grief counselors and sharing growing through grief impact that is happening across the 16 partnering districts where support is provided. Welcome, Nicole.
All right, thank you. All right. All right, can you see the slides okay?
Not just yet. I think it might be taking a second.
Okay. All right, I closed out and came back in. Is it still pausing
I
or
think
is
it's
it?
working on it. Just wait, maybe wait 1 second. Seems like it's slow to share today. All right, I can see your slide deck now.
Okay, wow, that was long. Okay.
Sorry.
Well, no, that's not your fault. Uh, Good morning, everyone. My name is Nicole Barnes, and I am a program manager with Park Nicollet Growing Through Grief. We are here today to share a little bit about the Park Nicollet program. Uh, we're looking at outline why childhood bereavement is in need of support and understanding the prevalence of childhood bereavement, how the opioid epidemic has impacted childhood bereavement, and then highlight some resources. So, in order to accomplish those objectives, we're going to look at the Growing Through Grief model and see how that relates to our topic today. So, Growing Through Grief is a school based specialized grief counseling and education program. We provide weekly in school peer support groups and individual counseling sessions. We also provide collaborative crisis response. So, if there's a death of a faculty member or a classmate, we work with the school staff to respond to that. And then we work on breaking down stigma by providing coaching, education, and professional development to the school staff. This whole program is a vision of the namesake of our program, which is Katie and her family. They're the legacy of our program. And Katie's father was in the Park Nicollet Hospice program over 30 years ago. We've been operating for 28 years. And 30 years ago or so, her father was in the hospice program and he passed away. And the family found that there weren't a lot of support systems in place for teens and children. And as a result, Katie chose some coping mechanisms that weren't in her best interest and had some unresolved grief, and she had died in her 20s. When the family reflected on the father's death and Katie's death, they came back to Park Nicollet and said, we really need to do something for kids and children. And so the foundation and the hospice program got together to talk with them and think about it, and they developed this barrier-free model that is supporting kids who have experienced death and bereavement. The model is barrier-free in the sense there's no cost to the students and families. There's no transportation required. We go to the children in their school setting during their school day. We do not have any place that the children can go to see us. We will only go to the children. It's open access. Kids grieve developmentally And grief can look differently depending on their age and milestones that they're going through. And so our program is designed to be open access all school year long and for consecutive years. So the way that looks for kids is once they experience a death in their lives, they get access to their own personal grief counselor until they graduate. And the way they can use that counselor is really up to them. They can come weekly and participate in a group. They could participate in a one-on-one session, uh, or they can take a break for a year and then come back the next year. They can come back during confusing times like milestones when they're regrieving. So there's lots of options for them, and the program in the family's vision was created to be barrier free and open um, access. With this design, the the secondary goal is to reduce the stigma in our children's lives as far as receiving grief support. We do not believe grief support is anything special. It's normal and necessary, and it's what we do when we have an experience that involves death and bereavement. So, what we're trying to do is when kids have that experience and they don't have a lot of options for support, the Growing Through Grief program is there for them and available anytime they need it. And so that is a little bit about what we do and how our program came to light. We started with one group in 1998 and one school. It was a high school and a part-time grief counselor that was hired through our hospice department. Today we have 9 grief counselors, and we have 16 school districts that we contract with and over 124 schools. We have 135 grief groups, 928 students that are in weekly support, either group or individual. There in 2024, we had 19 death-related crisis events, which resulted in over 13,000 students, staff, and families being supported. So you can see over the last 28 years, the the family was legitimately right when they said we need to do something different. We need to respond and make a program that's available for these kids. And obviously, when we did that, the kids participate and find safety and connections. So why? Why do they respond? Why is there such a need? Well, first of all, childhood bereavement is a public health issue that has long been overlooked. The death of a caregiver or other important person in a child's life is commonly reported as being one of the most disruptive childhood experiences. Death of a caregiver was not on the original list of ACEs, adverse childhood events that were studied, but since that original list came out, several studies have shown that the adversity related to experiencing a caregiver's death is quite significant for children. And the prevalence. Oftentimes, when we think of childhood grief, we or just think of grief, we don't always think of the children first. And so the prevalence is oftentimes higher than what we would anticipate. So across our nation, 1 in 12 children in the United States will experience the death of a parent or a sibling before they reach the age of 18. In Minnesota, which is where I'm from, we have 1 in 15, which comes down to 89,000 kids. And then I broke it down by state for those of you who are here from different parts of the region where you can see the ratio and then the numbers that align with that ratio. And these slides will be shared so you can look at that. But the reality is this 2022 number, it shows us that over 1,000 children in the United States are newly bereaved each day. And so there's definitely that Katie and her family were right on. There's definitely a need to do more and to care for our kids. What happens if we don't care for our kids when it comes to bereavement? Well, this graph is a good representation that makes it visual and a little and easy to understand as far as the consequences if we don't take care of our children during bereavement and grief. Those dark blue lines that you see pushing down, that's the related adversity. Um, that's the grief experience itself and then the related adversity that goes with it. So it's complex. There's many losses when we experience a death, not only the death, but it can also be our home, the financial strain in the home, loss of community, mental health concerns. So there's so many things that can go with um, our 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 experience of death and loss. So uh, that green dotted line is healthy development, and you can see that curving upwards. That's where we want our kids. But the heavier the blue lines get, the closer we get to dropping below that and having disrupted development. And the ways to protect ourselves from disrupted development is to increase our protective factors. So you can see those light blue lines moving up or arrows moving up. Those are the protective factors. Now, there's some kids who have a great wealth of protective family factors in their life, maybe family, faith, community, but then there's many kids who don't have that. And they need protective factors and they need programs and research, like we just heard, to help people understand the importance of the need to support childhood bereavement. And so our goal is to keep kids moving in a direction where they can develop and persevere and be cared for in that process. So the death of a loved one is identified as the most common and most distressing form of adversity among youth and adults. And bereavement is the strongest influence on school outcomes, above and beyond any other form of trauma. This is some research that came out and helps us understand why it's important to support childhood bereavement. In schools, we used to think of childhood bereavement or childhood death experiences as low frequency. It has become more frequency since our post-COVID years. Um, but not only has it been low frequency, but it's also high intensity. So the comfort levels and the confidence around talking about grief aren't always real high because we have our protective factors as caregivers and in place when intensity gets high. And so collaborating with specialists and knowing the research that's out there is really important for schools so that their comforter and confidence that can be elevated because schools are one of our greatest protective factors for kids. I want to speak about bereavement as far as the impact on BIPOC student populations. You can see the ratios on my right-hand side there, where the number of kids who will experience a parent or a sibling death before they reach the age of 18 by race. So the other important thing to look at is household income. So children under 18 in our lowest income homes are more likely to experience a parent or a sibling death. And how much more likely you can see by the percentages below. And I broke it down by state. So you can see by your state how much more likely those low income households are likely to experience bereavement. So the impact of the opioid epidemic, uh, post-COVID, our four leading causes of childhood bereavement are COVID, accidental overdose, which is the number one cause across all races, and that's where your opioid epidemic falls into place mostly. Those are all drug overdoses outside of homicide and suicide. Then there's homicide by gunshot violence, and then suicide. And these are causes of parental deaths. So deaths of adults that are of parental age, the most common for leading into childhood bereavement. when kids in our program identify the cause of death, you can see that about half of them are medical, the other half are a bit more complicated. Kids don't always know the cause and the relation, but we definitely have a portion of our kids that do know as well. We have 10% that are alcohol and drugs, and oftentimes the medical can fall into alcohol and drugs as well. All right, this slide is a little bit complicated, but I'm going to break it down for you. This is national representation. It is the amount of deaths in adults that are of parental age, so 25 to 54. So we're looking at childhood bereavement. So these are the average annual adult deaths by cause. So annually across our nation, we have over 300,000 deaths by all causes. The number of deaths of parental aged adults is that are drug induced is 38,573, which is about 12.8% of that overall. And of opioid related is 25,000. So what are the trends related to this? Nationally, the percent of children entering foster care due to parental substance abuse, 39%. The number of opioid prescriptions per 100 people is 58.7, more than half. And the number of opioid-related substance use treatment admission for adults aged 25 to 54, 1 in 283. And then again, our number of deaths that are drug-induced, 12.8. Here's a nice visual that can show you how the epidemic has significantly impacted our children. It's increased 3.5 times from 2002 to 2022. Accidental overdose accounted for 6.5% in 2002. And the deaths experienced in 2022 is 23.4%. So quite a difference. Ways to respond. One of the biggest ways to recognize the need for childhood bereavement is in November. National Children's Grief Awareness Day is in November, and it's always the third Thursday in November. And it's a day that where we can build awareness and help people understand that there are children that are grieving as well and in need of support services. There's ways to find programs or camps that are near you and available for students, and you can all these are linked in here. The National Alliance for Children's Grief has resource toolkits for schools and for communities to help support childhood grief, all very free and accessible resources. Here's a podcast that was put out by Growing Through Grief last National Childhood Grief Awareness Day. This is a podcast that is an example of how we can create awareness in our community. There's also additional resources. The coalition is specifically for schools and supporting schools around childhood bereavement. And Judy's House, they do a lot of the research related to understanding childhood bereavement. A lot of the numbers that I provided were generated from Judy's House JAG Institute. So let me check the time here, make sure I'm doing okay. All right, I'm gonna just run by these last few slides to help you understand how children look at grief. So we start by talking about the definition of grief. And basically what we want kids to know is that it's natural, it's normal, it's necessary, it's universal. Everybody experiences grief. It's unique. Everybody has a unique story around grief. It's ever changing, so it doesn't look the same from grade to grade. And it's never ending. It's more something that we are managing, not something that we are fixing. So a lot of discussion around this every time we meet. And we also talk about what grief is not. We talk about it not being pathological in nature, that it can coexist with mental illness, and it often coexists with psychosocial stressors because of all the secondary losses. the four concepts that kids are trying to figure out when they're trying to understand death is, and this is important to know because as they are talking and in conversation, their questions often relate to understanding these four concepts. So death is irreversible, all life functions end completely at the time of death. Everything that is alive eventually dies, and there are physical reasons why somebody dies. And of course, their age, their language, their knowledge, coping skills, culture, and experiences will all also influence how they understand grief. But no matter what the age of your child that you're working with, there's three main questions that I always think about when I'm hearing them talk and have conversation with me. Did I cause it? Can I catch it? And who will care for me? Almost all of these conversations come down to one of these questions. Who will care for me? Did I cause it? A lot of guilt is associated with children in the death process. And so wanting to know about causing it, wanting to know if I'm going to catch anything, if it's going to happen to me, if it's going to happen to one of my loved ones, and who will care for me. And a quote to help us leave with students grief and pain is caused by the death and situation, not by talking about it. So making sure that we build into the conversation of talking about it and help children feel safe in that process. It starts by just acknowledging and then building along the way as they feel comfortable. I'm going to pass on the video because it is and I am going to stop sharing and we can open up to questions.
Wonderful. Thank you so much. Lots of great resources shared. I want to open up the floor to our participants. If you have any questions or things you'd like to share. I did have a question for you, Nicole. You had talked about when you were talking about the number of students that you're currently serving in your program. It was like 928 that are in weekly programs. And I thought I heard you say that you have 9 grief counselors across the schools. How does that work? That seems like a
That's a
lot
good
of
question.
kids, a few grief counselors.
Right, right. So each counselor manages 2 school districts and they move from school to school. They average about 15 to 20 schools per week that they're seen at. And when you're doing groups, you may have 5 in a group, you may have 8 in a group or 10 in a group. So when you add those 9 up, then you get 938 kids. Yeah.
And I'm curious then, Allison kind of talked a little bit about some of the service provider grief, that secondary grief. Are there like certain things that you have built into the program for your grief counselors that provide support?
Absolutely. Yes, we have monthly check-ins to debrief and do a self-care time together. We have self-care partners that are checking in with each other and making sure that things are okay. And we just strongly encourage that people take the time. So we provide time for self-care and then we encourage them to take their own time as well and make time for that. We're also very flexible. We're not a come to work, get the task done and go. We have lots of flexibility because when you're dealing with emotional states that kids are in, nothing's really predictable. And so you have to have flexibility and making sure that we're kind we're flexible and we're kind and understanding the need for that and how to make that happen. So we will do the best we can to cover and share work and absorb work when we can, and just give somebody a break when they need it. So I think Allison's qualitative quotes that she shared were really good, and kind of demonstrated the emotional toll that people take on when they're grieving. And you never, it's not a one and done thing. Grief is something that's ongoing, and so those things can pop up along the way, and sometimes it catches kids by surprise as it would adults. And so it's just having that access available is so important. And the same thing goes for the counselors who are giving the care, having access and understanding of knowing when a break is needed, and how to, that you can trust somebody to hear you and understand your need. It's really important. uh, so thank you for that question. And just a shout out to Allison's work around qualitative research. That is not easy work. That's very time consuming work. And I just think it was wonderful to see that presented so well, and sharing those words of different people and how it impacts them. So very good job, Allison. Mhm.
Thank you, Nicole, and thank you for the work that you're doing, because I think the qualitative research really points to the need for much more of the types of programming. And it's important to also think about children, although I haven't done research on the experiences of children who have lost a loved one to drug overdose death. This is a very important area for consideration and specific support for those experiences.
Mhm. Yes, thank you. So true.
Any other thoughts or questions from the group? All right, I am going to drop into the chat a brief survey, and I'll just share with you all really quickly here, if I can bring my screen back up, just to kind of wrap things up here. So we mentioned that this project is funded by SAMHSA, and so it's really important for us to be able to share back your experiences from attending these types of events. So we do have a feedback survey there. And as I mentioned earlier, usually it takes about a week, sometimes two, to get the content up onto the website. But we will share with you all the link to where you can find it, the ROTA resources, and really just a huge treasure trove of other similar presentations around substance use disorder and recovery in communities. So you can kind of dig around in there as well, and we'll have more upcoming events, again, that are open to anyone, within the region or outside the region even. And then if you would like a certificate of attendance for this today, we can make sure you get that as well. So any questions from the group? Here's some of our links. Again, I'll make sure that you all have access to that. If you want to receive some of our updates and other upcoming events, be sure to sign up for that newsletter, and give us a follow on Facebook. Thanks so much for being here, everyone. I hope you have a wonderful day.
Thanks, everyone.
Thank you.
Thank you so much for moderating, Kelly, and thank you so much to our presenters. I'm just really overwhelmed with the data and the impact of this